Hey guys, this is Austin Nakatsuka here, and I have a dislocated lens that you can see here that is iris fixated, but right now it's only iris fixated on one side. So one of the haptics came loose on this patient when the patient basically had a really big fall. And this is a young patient, history of congenital cataracts that was done early in life and basically had some lens problems early on. And so this lens was fixated to the iris because it wasn't where it was supposed to be. But it was doing fine for a couple of years, and then this patient had an accident, and this lens dislocated. So here I did my marks and set everything up. And what I'm trying to go for here is I'm trying to go ahead and refixate this three-piece lens. And the reason why is because I have really found that when you are able to refixate the lens and not bring it into the anterior chamber and not make a big incision and do all the gymnastics needed to kind of bring that up and take it out and then put a new one in, which is no big deal if you have to, but if you're able to avoid it, it just turns out so much nicer and smoother, especially for the post-op care of this patient, and you'll see that in a second. So here I make two paras, and very carefully go ahead and grab this here, and I pull that out from the suture that's holding it to the iris on that side, and that was the only thing that was holding it. The other side, it's not. Okay, so I kind of gently just slid it out. And a lot of times I'll just leave, in fact, most of the time, I'll actually leave those sutures there in the iris because essentially they're not causing any problems. And when you cut them, it's very easy to cut the iris and you could just drop the suture. So there, I went ahead and pulled it into the anterior chamber there. And it looks okay, but there's one big problem here. Can you guys see it? Yeah, the lens is upside down. So right now it's upside down. It's in the S configuration with the haptic pointing to the right side, and S means stop, right? So you don't want it to be upside down. So I have to flip it back to the Z configuration with the haptic pointing to the left side here. So now I got to do a little bit of some gymnastics in the eye, and here I am flipping it, and I'm very careful not to scrape the cornea with it. So I actually have to push that lens down back into the pupil for it to flip nicely. I got to be careful with that haptic because it's made out of PMMA. This is a MA60AC lens, I believe. So I was able to do that without scraping too much of the cornea there and was able to very carefully flip it over. And now it's in the right configuration. And so I bend my needles and get that all set up and ready for my refixation. And so this part is just like a regular Yamane fixation. 2mm tunnels, 2mm away from the limbus. Not too badly of a dilated pupil. It could be better, obviously, but in this case it's kind of nice to have a scaffolding for that lens to be on. Externalize, and this started bleeding. So this patient, I actually had done a Yamane fixation for an iris fixated lens on the other eye too, and that lens was causing UGG syndrome, uveitis glaucoma hyphenoma syndrome. So I did that and everything went absolutely fine, and then that patient developed a big choroidal hemorrhage in that side, and I don't know why. It was just from the needles, and that patient bled, and it seemed really worrisome for a while, but actually just went away with medical treatment. And so this time I was really careful and didn't have him on any blood thinners or anything, but he still bled there, and so I was worried about that. I didn't like that. But he didn't end up having a choroidal hemorrhage afterward. But it just looks not very nice, obviously. Ooh, and that looks real nice there, huh? Really nicely centered. You can barely see the optic-haptic junction there. I really like that. So I went ahead and melted this side and fixated this side. Alrighty. That looks really nicely centered there. Oh, yeah. Oh, look at that. Love that. Beautiful. Love when you're not seeing any of the optic haptic junction underneath the iris there. It's really well centered. Looks really nice. Um, Sometimes I'll mark the center of the eye um, in the light reflexes to sort of make sure that it's centered. I didn't do that this time around, but it's not a bad thing to do either. And then here I'm doing a little bit of a vitrectomy here just to make sure um, everything's okay here. And when I do this, sometimes I will kind of do a little bounce test and kind of touch the lens and push down on it and bounce a little bit just to make sure that it's solid, that it's stable, well centered, and it's that the haptics don't pop in, which you do have to be careful of with these PMMA haptic bulbs. They can pop in through the sclerotomies because the bulbs don't get as large as the CT Lucia lens bulbs. So don't push too hard, but you just want to make sure that everything there is stable. So here I was looking at it and there's a little bit of pigment there, so I said, okay, I'm going to do a little bit more back behind here. And so I did. I went underneath and around. And so that's the nice thing about the Yamane fixation is it's usually pretty darn stable, so you can kind of go around the lens. You don't want to push it too much, but you can go around the lens if you have to. So why didn't I do a pars plana approach with the vitrectomy? I totally could have, yes, I totally could have, but because of this patient's history of the choroidal hemorrhage, I wanted to avoid as many pokes through his sclera as possible. So, so I didn't. I didn't do it a pars plana approach, which I don't do that routinely anyway. Um, but you know, some say that's much safer, and I can see why, and they're very comfortable doing it. But I did an anterior approach because I'm trying to do everything through this clear cornea as much as I can. Because look at all that blood that's there, and with his history before, I was trying to avoid a choroidal hemorrhage. You know, that's the other thing about do any pars plana incisions when you do this combined with the retina surgeons is that a lot of times you have to close those up because they do leak and then they can cause hypotony. So a lot of times you have to suture it up. And if you suture it up with a vicryl suture, the patients feel it afterward and they don't like it and it doesn't look nice. It gets really inflamed and ugly and red. So I try to avoid that if I can and do as much through an anterior approach as I can because, oh boy, look at that. That looks really nice and clear there. That cornea and the lens is so well centered. So, and here I am putting a little PI there, nasal PI with the vitrector. Just a small tiny one is just fine, and then I'm hydrating the wounds. And so this is all done through 2 paracentesis incisions. So this patient the next day looked absolutely fabulous. The cornea was really clear, young patient too, but you know, we didn't do a whole lot of stuff in the anterior chamber. And you know, only 2 incisions, so I don't have to worry too much about leaking incisions. I mean, you want to be careful, of course, but it's you know, much less likely than a larger incision that you have to put extra sutures in. It just looks nicer and more pristine afterward. It looks prettier and feels more comfortable. So if you're able to save a lens that's in there, a 3-piece lens, and try to do so, it's just a nicer, cleaner surgery. So that all went nicely, and thanks for watching my case.